Hey, everybody. Great to be here with you for our podcast about hepatitis B. I'm really excited to have a conversation with my colleague. I'm Elizabeth Goacher. I'm a physician assistant. I work at Duke University Medical Center in Durham, North Carolina.
And I'm Allison Moser. I am a transplant hepatology nurse practitioner at Rush University Medical Center in Chicago, Illinois.
Awesome. Great. It's great to be here with you. I mean, we're recording this at GHAPP, and it's really great to be here at this meeting. It's really going well. So exciting. I mean, I think the energy has been really good.
Yeah, it's been a great conference so far. I'm really excited to see all the hepatology content today and tomorrow.
Right. And we want to talk about hepatitis B. And so I've had a few questions, and I know probably you do too. So let's throw out, just to get started, here we are in this time frame. We're looking at what's new in hepatitis B. What has changed? And are there any things that you're seeing come out different that we need to be altering or thinking about in our patient selection, about who we treat, how we treat, when we treat?
Yeah, I think there's been a really important update in the EASL guidelines regarding when to treat patients. Our current guidelines for AASLD mention e-antigen status. So if the patient's e-antigen positive or negative, the treatment is different. EASL's come out with new guidelines that regardless of e-antigen status, if the patient has a DNA level of 2,000 or more in combination with an elevated ALT or high risk for HCC, other risk extrahepatic manifestations as well, that the recommendation is to treat.
Yeah, that's great. I mean, getting down to like any kind of virus, like kind of lowering the threshold for when you want to initiate therapy, considering that these other factors, while they're not like screaming in your face, there's something you should be taking into consideration. Any virus potentially can be damaging, especially if you're adding in these other things. I mean, I think that also mentions that regardless of the fibrosis status too, right? So we're looking at this regardless if you're fibrosis, we're just going on the DNA levels.
Yes.
In these subgroups like you were talking about, yeah.
Yeah, because we know that with a elevated DNA level, patients are at higher risk for HCC as well as development of cirrhosis. So really lowering that target to help these patients overall.
Yeah. Don't wait until there's something really, I guess basically when you say we're not waiting for more evidence of their future being bad. We know it's going to be potentially bad. Let's not wait even longer before we see that change, which I think fits a lot with my approach to hepatitis B because, we have great antivirals. They're highly effective. We know they have low likelihood of being problems. It's not zero, right? So we do see some changes long-term, potentially with bone health or with renal function, but those are not common. And so if you've got virus, get rid of virus. I mean, I'm really ready to move into the era of, we have something to use. Why are we not treating and getting people to zero? There's people maybe who shouldn't. They have bone health issues. But if you don't have those issues, why would you hold off? Any virus that you can get rid of, reduce the risk of transmission, reduce the risk of uncertainty. I think you guys we were talking, earlier. I have a patient that's just what she's like, no more uncertainty, Elizabeth. I don't want to wait until I see a signal that I have to worry about. I'm worried now. And so we really had a patient-informed discussion. It's definitely not in the guidelines, but it's something that as long as she's aware of what she's up for and taking that into account, she's been much more comfortable that way. So I think that's important to engage our patients in that, where they stand on antiviral therapy and what they think. Do they want to be on a drug or they do not, right? So.
Yeah, I have similar things, but more so patients are not wanting to start a drug because they know that they're going to be on these medications lifelong. But which antiviral are you tending to choose, or how are you addressing that with your patients? Which one are you your go-to?
Yeah, and fortunately, I think in the current era, I'm seeing very little formulary restrictions because historically, any drug, any disease state, the answer to that question initially was going to be, well, what does the formulary cover, right? And so for the most part, we're seeing really, ease of choice. We tend to lean towards TAF or tenofovir alafenamide when we can get hold of it because it does have a better safety long-term or longish term. It's not really long-term drug. It hasn't been around that terribly long, but not certainly as long as TDF. But if I could, I always get TAF or tenofovir alafenamide. If I can't, though, I talk with patients and say, look, here's the deal. This is tenofovir alafenamide. It's got a cleaner renal profile, and we obviate any concerns with the long-term use that you can see with TDF, even though it's a low rate. And we talked about what they want to choose. Entecavir is usually something I do use if it's a formulary choice, just because it does have a lower barrier to resistance, lower barrier to resistance over longer term. So I try and stay with it, but it's still really good. Just because it's slightly more likely to have resistance doesn't mean it's not a good drug for a lot of people. I don't know. What do you think about when you're talking to your patients?
Yeah, similar to you. I mean, I do look at their renal health or bone health. If those are issues, then I prefer to start TAF. But yeah, overall, I would say that's my preference, unless there's a reason why I can't.
Yeah.
But in special populations, like in pregnant women, historically, we've used TDF because there's been the most data regarding that. However, recently, EASL updated their guidelines that now we cannot use TAF in patients who are pregnant in addition to TDF, which we're still waiting on AASLD guidelines to be updated, but
nice. Nice to have that, when you have a statement behind you, because the science is probably sound, or not probably, definitely it's sound. That makes sense. Moieties tend to be that way, right? Because they're just cousins of each other. But having that statement of a society behind you really helps you when you're having that conversation with patients and charting too, right? Documenting the different risks and benefits of things. So, you bring up patient factors. So one of the things I think about for patient factors when it comes to selection too is, like you said, one, patient preferences about use of long-term medicines. And I think there's two camps. There's the people that are like, I want to avoid this as much as possible. So monitoring is great and helpful if they'll do the monitoring. But also the people who, the flip side, do you want to be on a chronic suppressive therapy because it helps them with they've got the fear of the families. They know their grandmother had liver cancer. And so maybe they don't quite meet the traditional guidelines. But those are things I put in there. I also put in compliance too. I'm like, is this a person that if I start this therapy, they're going to be able to have it continuously? I don't know what you think about that when you think about continuity of therapy. What's the risk of starting a therapy and interrupting it? Is there a downside? Is there an upside? And trying to have that conversation. I don't know if ever comes up with your patients.
I do. I definitely think there's a downside. I would rather just continue to monitor my patients with labs, HCC surveillance with the ultrasound, AFP2 marker if they meet those high-risk criteria, than starting and stopping. I do make it a point when I'm starting an antiviral on one of my patients to talk about compliance and adherence, how important that is with these treatment of hepatitis B. One thing, when I see the virus level start to go up, because you had mentioned these medications have such great efficacy and resistance is very low, the first thing I think of is adherence. So I think that's always something to be thinking about, but a good conversation to have with your patient before you actually start them on therapy.
Absolutely. I mean, we know these drugs, tenofovir in particular, so effective, so unlikely to develop resistance. So if you're seeing virus, is it really resistance? Because really, resistance is just not well reported with tenofovir. You just don't see it. So thinking about noncompliance. And I always take heart in the long-term follow-up with tenofovir, disulfoxyl fumarate, patients who were viremic in that cohort, their drug levels were always low, leading you to understand, that's where the compliance comes from. And then the good news is that when they got their drug levels back up, their virus went away. Again, adding to our, we know this drug just doesn't. I can't say it doesn't, but seems so unlikely to develop resistance. So I take heart in that. But yeah, you don't want, I don't want a person jumping on and off therapy because the risk of flare, right? And so if you got really active disease, which is the greater risk benefit, where does it fall? Suppress it. But if they're at risk for flare because they lose their insurance, because they don't have continuity in their general life skills, they're not medication compliant in the first place, we're going to have that. You're going to have to add that in addition to, which is worse, monitoring or being on or off therapy and the flares and risks. So I also think about my HIV, I don't know, with co-infected patients. So HIV, Hep B co-infected patients, I feel like we see low-level viremia in those patients. I don't know if you've experienced that as well, but sometimes it just seems to take those co-infected patients longer, if ever, to get viral negative. And I think a lot about the viral assays. I don't know about the assays you're using there, but the noise factor at those low levels. They'll be positive for virus, but are they really positive? Because it might be the assay. So I don't know if that's something your institution takes into account when they're looking at the different numbers. And especially with transplant, I know that might be more important. Is it really real virus or not?
Yeah, and we're always working with our ID colleagues as well on those patients, as they're a little bit more complex. But, the great thing about those patients is they are on antiretroviral therapy that has hepatitis B medications in it, so they're not having to take an additional medicine. I find most of those patients are usually compliant with those medications and get followed pretty closely.
Yeah.
So you can, not that every patient's going to be adherent, but higher likelihood that those patients would be.
General rule with my co-infected patients, I'm like, if their HIV viral level is under control, I know their Hep B is going to be okay.
Mm-hmm.
As long as, I think it's really nice to see some of the shift in the ID management that I've seen over the years to like including tenofovir as a choice for your co-infected patients. A lot greater recognition, I think, in the past 10, 15 years of the importance of having hepatitis B control and using that as a driver for your choices and what HIV antiviral is using. So as long as they're on a tenofovir containing compound or combination, we're good to go in my department. So as long as they're also getting their Hep B surveillance, right? So.
Yeah. I think one of the downfalls of our current medications are the lack of functional cure or surface antigen loss, very low rates of that. What have you heard about in terms of things in clinical trials or research that are coming in the future that might be more promising?
Yeah, these things that were like, a few years ago, I remember, seeing being, at AA, there's a cure coming. I swear it's coming in a few years, maybe 5, maybe 10. And here we are 5 years later and it's still not there. And I've told my patients that too. And they're like, Elizabeth, you said. I'm like, it's in the works. So, we're seeing some progress in add-on therapy. So patients who are on a nuke and who are getting good virologic control, their DNAs are under control, they're still surface antigen positive. You obviously don't stop their nuke, right? But do you add on these 2 new coming therapies that we're looking at, 2 different agents that are looking really promising? They're not, everybody gets it, and the rates are not 100%, but just even the concept that we might add on something that can make you lose surface antigen and get to a functional cure, that's really exciting. Not prime time yet, but at least hope. More hope than, I've been doing this a few years, and when I first started, that wouldn't even be something you consider that you could like therapeutically lose surface antigen. So just the concept is really exciting. So I really look forward. It's going to be another few years, couple of years to get to those endpoints, but exciting stuff. Yeah. Great. Well, I've had a great time talking with you. It's always fun, as always. Really enjoy the conversation. We really hope that you had a good use of this podcast. We hope it helps you in your clinical practice. We look forward to hearing and seeing you at GHAPP meetings, and we hope that you'll be sure and take up all the GHAPP offerings on our website. So thanks again.
Thank you.